Thank you for joining. My name is Saskia Reckon, and I'm a perfusion student here at the University of Arizona. And today I'm going to present my course for cardioplegia for perfusion students. So just as a general disclaimer, this is going to be mostly referring to adult cardiopulmonary bypass rather than pediatric. And then some of the anatomy figures we're going to be showing today are not 100% accurate, but they are very helpful in demonstrating the concepts. So we're going to quickly review cardiac surgery and the invention and implementation of cardioplegia in it. And then we're going to review the myocyte before going into discussing reperfusion injury and the mechanisms of cardioplegia. And then we're going to discuss the evolution from crystalloid to blood cardioplegia, review some of the clinical options for cardioplegia, and then talk about its delivery. So, cardiac surgery is a fairly new field of surgery. It wasn't until 1891 that Henry Dalton had his first pericardial wound repair. And then it took a while for them to have the first successful open heart surgery, which occurred in 1952, and using hypothermia to arrest or place that heart in ventricular fibrillation long enough to perform a successful surgery. And then a year later, John Gibbon introduced the first heart-lung machine, performing the first successful cardiopulmonary bypass procedure. And then in 1955, they used the first crystalloid cardioplegia. It was something called the Melrose technique. It was using a really highly concentrated potassium citrate that was later abandoned because it had pretty significant myocardial damage. But in 1979, they introduced a much more optimized potassium-based cardioplegia that is very similar to the high K, low K that we use today. So cardiac surgery itself really revolutionized the option for the type of surgeries you can do. It allowed you to alleviate the blood volume in the heart while compensating for any interruptions in heart and lung function. However, you're still getting a significant amount of residual flow, right? And so your heart's going to be still a little bit full unless you're putting snares, and you are still perfusing the coronary. So your heart is still beating and moving, making it not so optimal for really efficient and high quality surgical repairs. And in addition, you can't just cut off heart supply. Your heart is a very sensitive organ. It takes about 5% of your cardiac output, or 250 milliliters a minute of blood, and it will consume 65 to 70% of the oxygen provided in its resting state. That is about 7% of your overall oxygen consumption for your body, which is pretty significant for how small the organ is. And you can see here, your full beating heart consumes 10 milliliters of oxygen per minute per 100 grams of tissue. So even just cutting off supply in a empty beating heart or a fibrillating heart, you're still having a very significant consumption of oxygen with no supply. And even with hypothermia, it is reduced, but not significantly. It isn't until you start introducing cardioplegic arrest that you start seeing a significant reduction that's really protective. However, obviously at the beginning, they didn't have cardioplegia, so hypothermia was the best option. It was found to have about an 8 to 30-minute safe circulatory arrest time, in which case the heart would be either put into asystole due to no perfusion or stay in ventricular fibrillation for a while. Either way, you had about a 10% metabolic decrease. However, you still had really significant myocardial damage, edema, acidosis, dysfunction, ion dysregulation, and damage to the cells. So you can see here's a little summary about that. You can say that your 8 to 30-minute time constraint is a very small window for even the best surgeon. They're going to be hard pressed to have really high quality and extensive repairs. So that kind of limits your surgical potential, right? And then you're also going to have really high frequencies of myocardial damage. So patients are going to have hypotension, low cardiac output, arrhythmias, poor recovery. Overall, that's going to really increase your morbidity and mortality post-op. While it is better than nothing, it's not ideal. And then another condition that was really common with this was something called stone heart. So stone heart is when your heart is depleting over 60% of your ATP. So you get these rigor complexes that are stuck in like contraction state, and your heart cannot get out of that state because it has no energy to undo those complexes. And this is really commonly occurring when you have ventricular fibrillation beating in a heart that has no energy supply or metabolic supply, especially in hearts with really significant hypertrophy because they need more energy and the muscle is much thicker. So then they get stuck in that stone heart condition that is basically fatal. And so that was a really feared condition and one of the main proponents for getting cardioplegia implemented. And that's what they did. So cardioplegia itself is kind of made up of two main components. One is going to be hypothermia, which we just talked about, has a lot of positives for it, but it isn't enough alone. So you need that cardioplegic arrest to stop the electrical activity throughout the myocytes and decrease that energy demand. The first introduction of cardioplegia was kind of just the normal antegrade, either delivering through a syringe, or eventually they would have that cardioplegic crystalloid solution placed in a pressure bag and then delivered directly through the antegrade needle in that cross-clamped area, fusing down and arresting the heart and diastole to have that soft and still optimal operational field for cardiac surgery. Here's your little picture. You can have your antegrade needle here. Here's your vent where that needle's placed. You have enough room for the cross clamp so that it will be delivered at a high pressure, slamming the valve closed and arresting the heart. So the general benefits of cardioplegia are obviously you're going to get that bloodless and still environment that's ideal for operation. And then you get a really significant reduction in oxygen consumption. So with hypothermia alone, that's 10%. But when you add cardioplegic arrest and asystole, you get a 97% reduction in oxygen consumption. So that's the difference of 10 milliliters of oxygen per 100 grams of tissue per minute in a normal thermia beating heart to 0.15 milliliters of oxygen per 100 grams of tissue per minute at 15 degrees Celsius. So that's really significant. And obviously, it's going to really decrease your energy demand, allowing your heart to maintain and keep up with the ATP and metabolic reserves that it has to kind of improve your LV function and post-op recovery. And again, obviously, that's going to really decrease your mortality and morbidity post-op because now you have the ability to recover and have more ideal conditions. The other thing that's really worth noting with cardioplegia is that not only does it arrest the heart, but it does allow recovery of the heartbeat once you're done with your surgical operation, right? So all you have to do for that is going to be removing your cross clamp, allowing for that reperfusion throughout the coronaries, de-aering it, rebalancing your ion dysregulations, resupplying your metabolic and ATP reserves, and then paying back its oxygen debt until you have your reinstatement of EKG. All in all, this is going to allow for a lot more extensive surgeries, a lot more ideal surgeries and higher quality. So here you have a mitral valve repair. You can have that bloodless and still environment that's ideal. Here we have what looks like a redo aortic arch or ascending aorta surgery. This is going to be a very probably longer than 30 minutes, and it's something that's already been exposed to ischemia before, both pre-existing as well as under cross clamp. So you want to have the most optimal protection for that heart for recovery post-op. And similar idea, this is the pediatric heart. You can see how tiny it is. This baby is very, very young, right? And so that's your right atria opened up and your atrial septal defect or ASD is here. You don't want to pre-expose that baby's heart to any more damage or ischemia than it has to. And so that's why cardioplegia is really ideal for that. So that's kind of why cardioplegia exists. So let's talk about the myocyte before we go into the actual effects that cardioplegia has on the myocardium. So how does a heartbeat kind of start? Your pacemaker cells are the trigger. They have that slow, leaky sodium channels that are going to bring your cell membrane, your membrane potential up, triggering depolarization and then the repolarization contraction sequence. And that's going to be traveled across the heart by your gap junctions and your desmosomes. Well, desmosomes are holding it together, but your depolarization goes through your gap junctions, which are located on your interconnected discs of your myocardial cells. And these are going to be what translate that kind of synchronized wave of contraction. And then your desmosomes are going to be holding the cells together to have that actually strong, tight connection to enable contraction. All in all, your myocytes are kind of what's accomplishing that beating potential throughout your heart itself. And they have a resting membrane potential about -80, -90. And then they have that trigger threshold of about -70, at which those sodium voltage gated channels are going to be opened and initiate that rapid depolarization and total contraction sequence. So let's just review how the ions move throughout the general myocytes upon contraction. So you have depolarization, in which case your voltage-gated calcium channels are opened, and so calcium comes in. That increase of calcium intracellularly triggers your sarcoplasmic reticulum to also release calcium, initiating that calcium spark, and it's used in contraction itself. Upon relaxation, your calcium's released, it's getting pumped back into your sarcoplasmic reticulum, as well as out of the cell through your sodium calcium exchanger, and then that sodium turns around and gets pumped right back out in exchange for potassium by your ATP-dependent exchanger. The other thing we want to review is going to be your aerobic versus anaerobic metabolism. So aerobic is with oxygen, it's utilizing the Krebs cycle. You have a much more efficient production of ATP, and the byproducts that are made are going to be easily handled and disposed of by the body, so CO2 and H2O. And this is going to be most ideal for both cardiac function as well as cardiac contraction. However, in a ischemic environment, anaerobic metabolism is utilized. That is going to have a very significantly reduced production of ATP with only 2 moles, and the products that are made left over are going to be hydrogen lactate. All that acidity is really detrimental to the cell. It not only impairs your cell's permeability, but your cell's function, and this overall kind of metabolism is only ideal or useful for cellular repair and not continuing normal myocardial contraction, and it's not sustainable over time. So that's kind of how the myocyte works, right? So let's get into reperfusion injury. Reperfusion injury kind of is composed of both ischemic injury and then injury that we are inducing ourselves with both cardioplegia delivery and then reperfusion of oxygenated blood after that period of ischemia. So we're going to first kind of talk about just the determinants of ischemic and reperfusion injury. One is going to be really age. So age really has a significant effect on the necrosis and the type of damage that a patient is going to encounter, as well as the metabolic state of the myocardium, temperature, nutritional and hormonal states. Gender does have an effect on your hospital mortality rates. That has nothing to do with anatomy, but has to do with how they are treated and taken care of, which is a whole other issue. But still very relevant. Your disease state the patient is in, so hypertrophy, diabetes, hypertension, chronic ischemic heart disease, all of these things are going to have to play a role in your post-op recovery and exposure to ischemia. Your collateral flow, your non-coronary flow, and then obviously your duration of ischemia. So both like your pre-surgery, pre-existing ischemic times, like they had a STEMI, chronic ischemic heart disease, as well as obviously the duration of cross-clamp. Your induced ischemic time is still relevant. While it is protected, it is still causing damage. Ischemia itself has kind of 3 types or 3 levels of severity. Your first is going to be seconds to minutes, so like angioplasties and cath labs, or angina with coronary artery disease. These are going to be kind of minimally they definitely have an effect, but minimal damage. And then you're going to have hours. So things like infarctions, cardiac surgery with cardioplegia, so our cross-clamp time, these are going to be more significant, causing more damage. However, they're not going to be necessarily detrimental always. And then year-long ischemic exposures, so that can be years, that can be months, etc. So things like chronic ischemic heart disease, things that are long-term existing that people are living through day to day. Overall, after 20 minutes of coronary occlusion, you get irreversible regional damage, and then after 30 minutes, you get necrosis. So you do not want this years and hours to be extended longer than needed. That's kind of the goal of cardioplegia and quicker cross-clamp times. But how does that ischemic patient present when they're coming in or when you're reading their chart or post-op? One, you're going to see some type of oxygen demand supply imbalance. However, that's going to present itself as really evident anaerobic myocardial metabolism, so acidosis, cellular dysfunction, necrosis. You're going to see that looking like low cardiac output, low ejection fraction, hypotension. If the patient comes in with a pacemaker already, they're having abnormalities of EKG and arrhythmias. They have wall motion abnormalities, and then you also see elevated elevated plasma enzymes and proteins. So like you'll notice in their chart, they have a really significant STEMI. You'll see elevated troponin levels or myoglobin levels. That's indicating that they have pre-existing ischemia. Now let's kind of get into the type of damage that we are going to inflict with cross-clamp, cardioplegic delivery, and then reperfusion. So these are kind of the main components that we're going to do. We're going to go over them in a bit more detail now. So the first up, we have production of oxygen-free radicals. Just to review, oxygen-free radicals are made because oxygen is a very reactive molecule, and when it has an unpaired electron, that can cause really significant damage on cells. They can really hurt the cell membrane, cell metabolism, cause lysis or apoptosis of cells. Although the function and presence of reactive oxygen-free radicals are normal and required for specific cellular processes, although they are normally mediated by antioxidants. So antioxidants are also naturally present in the body, and they both mediate the damage as well as regulate the amount of reactive oxygen species that are present. So in ischemic environments, you have production of reactive oxygen species. However, they cannot be mediated, their production isn't mediated by antioxidants because antioxidants only work in a normal pH. So when your pH gets out of 7.2, such as in an ischemic and acidotic environment, these oxygen-free radicals are having an unmediated free production across the cells. And then they get this exposure of really highly oxygenated blood getting reperfused into the myocardium while it's still acidotic, and it gets an explosion of ROS production that is still unmediated by antioxidants because it's still in this acidic environment. So that's kind of the really significant damage. We have a little depiction here. So you have your decrease in oxygen, increasing your lactate and your overall acidotic environment, causing an increase of reactive oxygen species, as well as really increase with that reperfusion of highly oxygenated blood to that ischemic acidotic environment. And that causes really significant damage to DNA, lipids, proteins, so cell membranes, etc., causing cell death and apoptosis. And that isn't going to stop until your antioxidants are reinstated with their function at a normal pH. Okay, next up, we're going to talk about a little bit of endothelial dysfunction. So one of the really big mediators of endothelial dysfunction is going to be nitric oxide. And in ischemic acidic environments, nitric oxide isn't made as much. So there's a really high unmediated release of inflammatory factors, leukotrienes, migration of neutrophils, etc., all of which is going to cause really significant damage to capillaries, as well as inducing something called a no reflow phenomenon, which we'll go over in the next slide. But it can also trigger your inflammation cascade, etc. One of the treatments for that is something called the leukotriene depleting filters. However, it's not widely used, but it can happen, or can be used if it's really significant. And then your microvascular inflammation activation is really triggered. It will both respond to ischemia and hypothermia. So that inflammation cascade will be activated and cause increased damage to the myocardium, all of which kind of decreases the perfusion and reperfusion throughout the microvascular system of the myocardium. So here's kind of a summary about that. So your neutrophils get activated by ischemia. They release cytotoxic granules and reactive oxygen species, and then they go throughout your capillaries, causing damage, and they kind of create this like obstacle course because they are getting cellular aggregated platelet, kind of like coronary artery disease almost, and they cause this no reflow phenomenon where you can't reperfuse or get perfusion throughout the myocardium because it's so aggravated and reactive. Next up, we have calcium loading. Calcium is one of the most important factors in ischemic reperfusion injury because it has such widely affecting damage and it can affect so many things. So calcium loading itself causes diastolic stiffness, myocardium dysfunction, and then ATP depletion. And we'll go over kind of the exact mechanism of calcium loading in the next slide. But overall, with really significant calcium loading and ATP deficiency, you can have like stone heart still induced, regardless of your cardioplegic delivery. So you want to be really careful about this. And it's also why you want to be very conscious of delivering or adding calcium while you're cross-clamped or right after cross-clamp because of this. But overall, calcium loading happens when you have really, you deliver your cardioplegia, you have a high extracellular potassium concentration extracellularly. So your heart is trying to count for that, and it's using this ATP exchanger at a high rate. But that will quickly deplete your ATP supply because you have no continued perfusion or supply. So this shuts down and you get this overaccumulation of sodium intracellularly. Your overaccumulation of sodium intracellularly does a few things. One, it's going to lower your cell membrane, triggering these voltage-gated calcium channels to open, allowing calcium in. And then two, the use of sodium and calcium in your anaerobic metabolism will increase it. So you'll have a higher concentration of hydrogen intracellularly as well, making it an acidic environment. It'll also kick this exchanger into gear, trying to get more sodium out, which in exchange brings more calcium in. And that, again, exaggerates your anaerobic metabolism, as well as your diastolic stiffness and ATP depletion. So you get one, high levels of calcium intracellularly, and then two, you still have high levels of sodium intracellularly. And sodium intracellularly will pull water in because water follows sodium. So then you're also inducing cellular edema intracellularly. So it's like a whole world of bad things going on there. The last thing to note really significantly with potassium cardioplegia specifically, which is what we use most commonly, is hyperkalemia. So your normal concentration of potassium is like 3 to 5, right? But your concentration of potassium in cardioplegia is 10 to 25 millimoles. And hyperkalemic effects begin at 7 to 9. So you're definitely in the range of hyperkalemic effects. And so that's going to present as arrhythmia, so failure of conduction, left ventricular dysfunction, low cardiac output, coronary contraction. So you're going to be limiting both your cardioplegic delivery as well as your perfusion delivery. And it does induce microvascular damage, increasing inflammatory response. It does exaggerate calcium loading, because we talked about before, that more dysregulation, the more your cell tries to compensate, depleting its ATP and increasing your ionic imbalances intracellularly. We can see here, your depolarizing arrest is what your goal is, right? So this is going to be the range of depolarizing arrest. That is also the range of hyperkalemia. So yes, you're getting membrane depolarization, so arresting in diastole, which is what we want. You are also going to be getting a lot of these negative effects. It's kind of the good comes with the bad. And different parts of the heart are going to react with different sensitivities to calcium. And that reaction is also going to be mediated by the levels of ischemia and the level of hypothermia. So the colder it is, the more ischemic environment it is, both pre-existing as well as longer cross-clamp, the worse those hyperkalemic effects are going to show up. But overall, just again to review, the determinants of both ischemic and reperfusion injury together are going to be really significantly for our use, our fault is going to be the duration, so how long was your cross clamp, as well as what is pre-existing. So if it's pre-existing really bad and you have a long cross clamp time, you got to be looking out for kind of the presentation of reperfusion and ischemic damage post-op and weaning. The amount of collateral blood flow to the heart, the amount of oxygen demand, the function, hypertrophy, your age, the temperature at which you arrested during ischemia, your buffering capacity, so how much how long was your heart remaining in that acidic environment, and then your edema induced. So is it really, really edemic? Because then your contraction ability as well as your cell membrane permeability is really dysregulated and it can't recover as well. But overall, post-op and weaning, that's going to present looking like hypotension and cardiac output, low cardiac output. So how many pressors is your patient on? More is worse, right? Are you going to require a balloon pump? Do you need VA ECMO? The worse it gets, the more kind of damage that you can know that is induced on the heart. Are there reperfusion arrhythmias? Are they pacemaker dependent? Do they require shocking to come back? Do they require a significant amount of antiarrhythmics? You can take note of your systolic and diastolic dysfunction. You can notice that through your wall abnormalities or your cardiac output. You can see on the TEE how well is the right heart or left heart moving, as well as your endothelial dysfunction, which might be a bit more noticed in your labs post-op or your longer term recovery, but it is still very relevant. So overall, those are kind of the bad things that we induce with cardioplegia and cross-clamp time. So cardioplegia itself is going to want to, one, arrest the heart to limit that, as well as have different additives to both mediate and reduce all of those reperfusion effects. So let's just talk about first the mechanism of arrest that cardioplegia does. So there's kind of three main ways of arresting. I'm going to cover depolarization because it's the one that's most commonly known, but it's utilizing usually potassium to decrease that resting membrane potential to about -50, -60 to stop those sodium voltage gated channels from being initiated. So you can't have depolarization, that whole rapid depolarization sequence. Hyperpolarizing and non-polarizing is kind of the opposite. You're hyper or increasing the polarization on the cell, as well as giving an agent to incapacitate the sodium voltage gated channels to make the cell incapable of even initiating depolarization. And if that initiation was for some reason accomplished, it's going to be so low that membrane potential that it can't trigger your sodium voltage gated channels at -70. And then the last one's going to be your inhibition of calcium influx. This is kind of a third, less common mechanism because it's not as effective and you need really high doses of the calcium competitor to be effective. However, the idea is that you prevent calcium entry into the myocyte as well as displace it from its use in the myocyte so that you can't accomplish contraction or even get into the systolic function. So we're just going to mostly talk about the first two. So depolarization generally uses potassium, and it's going to be delivered through the coronaries, raising that resting membrane potential to -50, -60, and that's going to close about 97% or make the cell membranes unable to trigger about 97% of the sodium voltage gated channels, and it lowers the energy demand by about 81%. And you can see here, we're going to give generally a dose of 10 to 30 milliequivalents for that initial induction dose, and then about 10 milliequivalents per liter for each maintenance dose. And cardioplegia is the most common, or potassium-based cardioplegia is the most commonly used cardioplegia, both historically and currently. So in all, just to review, you have your resting membrane potential naturally due to both potassium and sodium. And then you have your resting membrane potential trigger at about -70. So you're going to give a really highly concentrated potassium concentration to raise that resting membrane potential to about -50, -60. It's going to close about 97% of your sodium voltage gated channels because it's so high it can't trigger. Now the rest is in diastole. So then your next is going to be hyperpolarizing and non-polarizing cardioplegias. So it generally utilizes two agents, your sodium voltage gated channels and opener blockers and your potassium channel openers. So sodium channel blockers are going to be doing that non-polarizing mechanism. They block the influx of sodium, thus stopping that cell from being capable of depolarization. And then you have your potassium channel openers, which accomplish that hyperpolarizing mechanism. They allow for excess potassium to come intracellularly and cause that resting membrane potential to become more polarized. They have a higher energy demand decrease, so it's 95% versus the 81% with depolarizing arrest. They have less calcium loading, fewer ionic imbalances, and they are protective against inflammation, oxidative stress, ischemia, and arrhythmia. So that's all really great. However, the disadvantage is that the agents that are going to be used have really adverse and toxic effects when they're given in the wrong amount or not like in the right mechanism. So you have to be very precise, and the route of delivery or the mechanism of delivery is more difficult, making it more complex and more risky a little bit. So that's kind of why it's not as widely used. It's also a newer introduction of a type of cardioplegia. So all in all, you have your potassium channel openers that are going to decrease your cell membrane to about -80, -85. And then you have your sodium channel blockers, which turn off or block this entire channel, stopping any type of potential depolarization trigger. So some of the agents that are going to be used for this, again, potassium is your most widely used agent for depolarization. And then you have lidocaine and adenosine. These are going to be usually used in conjunction, often adding magnesium into that, but these two are going to be used for your non-polarizing effect, blocking sodium voltage gated channels, as well as adenosine is a hyperpolarizing, opening those potassium ATP channels through the A1, 2, and 3 receptors in the myocyte. Here are some more options for sodium channel blockers, not as widely used but have been used historically. And the magnesium is used often as an additive to any and all cardioplegias, but it is what would be used individually for calcium displacement cardioplegia, as it is a competitor for calcium's entry and use in the cell. Again, it's the least effective, and it does require really high concentrations to be effective, so it's usually an additive and not an isolated agent anymore. Speaking of additives, there are a lot of reasons and agents that we're going to be used and add to cardioplegia in order to optimize those reperfusion injury effects, as well as kind of set up the heart for a very successful recovery post-op. So we can go over that now. So first up, you have buffering components. Buffering components are going to kind of try to mediate and decrease that acidic environment to kind of have ideal cell function, mitochondrial function, antioxidant function. Your pumps are going to be normalized, etc. So the most commonly used buffering agents are going to be bicarb, histidine, which is going to be present in blood as well, so phosphate, and then blood itself has a lot of these things naturally in it, which are going to be very effective, and that's kind of the advantage of adding blood on its own. Another thing you want to be really conscious of is maintaining a normal oncotic pressure, because when you have a really dysregulated osmolarity, you're going to induce serious edema, and that has really detrimental effects on cell function and the ability of contraction for the cells. So that's really not ideal for recovery. So you want to minimize that. You can use mannitol to do this. It's also a radical scavenger. Glucose, which is also a metabolic substrate. Albumin can be added directly or through blood. Sodium as well, same concept. And it can increase that extracellular sodium level to pull water out rather than allowing it to seep in. And then blood itself has a lot of these components naturally in it, and it has other natural oncotic pressure substrates. Next, you want to be conscious of membrane stabilization. So in a broader sense, you just want to restore membrane permeability and your normal ionic balances to kind of idealize and protect the heart from arrhythmia. So some of these things can include lidocaine, procaine, magnesium, as we talked about, corticosteroids. Calcium is an option. However, adding it into cardioplegia is a little controversial because it's kind of ironic if you're also trying to stop calcium loading, but that's okay. Most commonly, you're going to see lidocaine and magnesium as the use for membrane stabilization. Next, we have antioxidants. As we talked about before, antioxidants need normal pH to kind of mediate and reduce the damage caused by reactive oxygen species. So by increasing antioxidant concentration, and by trying to use buffers, ideally, you can not only normalize pH quickly, but also have an increased concentration of antioxidants to limit and control reactive oxygen species damage. Some of these antioxidants are going to be mainly mannitol. Blood also has antioxidants naturally occurring. And then L-arginine is an amino acid that's a precursor for nitric oxide, which we know, and that is a very effective antioxidant as well. Next up, we have metabolic substrates. So these are things that you're inducing a really ischemic heart state, and so you want to be able to reinstate as well as kind of maintain those ATP and metabolic reserves in the heart. So glucose can help do this, dextrose. Blood has obviously natural substrates for metabolism as well as oxygen, which is very useful in kind of maintaining your aerobic versus anaerobic metabolism. Glutamate and aspartate can be added. Ketoglutarate as well as insulin is sometimes added in order to kind of prompt those cardiac cells to increase their glucose uptake. Although I would say probably the most common ones are going to be your blood glucose combo for metabolic substrates. Next, we have agents that are going to prevent calcium accumulation. We talked about how detrimental calcium is, and it has multiple detrimental effects. So limiting that is very ideal. It also allows for more ideal recovery, as well as limiting the occurrence of stone heart, which is very much a goal for cardioplegia. Some of these agents are going to be magnesium, which is why it's a very common additive. It does so many things, but it is a calcium channel blocker and competitor. CP2D acts as a calcium chelator, so it's just limiting the available calcium for entry to the myocyte. And then sodium itself is a competitor, blocking the entry of calcium into the myocyte, by decreasing its action of the sodium-calcium exchanger. Okay, and then lastly, we have CCBs and vasodilators. The idea is that they want to prevent vasoconstriction with both like the hypothermic and hyperkalemic effects. But cardiac CCBs have been shown to kind of depress myocardial function and cause heart block, so they're not widely used, but some cardioplegists do add them still. One of those is going to be adenosine, which is also, as we remember, one of the hyperpolarizing agents in hyperpolarizing and non-polarizing cardioplegia. So that's kind of the example of using it in excess or wrong concentrations can be toxic, causing that depressing of myocardial function and heart block. But all in all, it is a vasodilator, and it does block, causes your, it doesn't block sodium channels. It, I think, opens potassium channels. Please ignore that. Okay, nitroglycerin, and then you have other CCBs that could be added to cardioplegia. Okay, so those are kind of all the agents that can be added and kind of the general potential makeups of cardioplegia. So let's just kind of go over the actual solution itself and its evolution throughout time. Our very first type of cardioplegia was delivered through a syringe, and that wasn't super effective. That was the Melrose technique, had pretty significant damage, and it was way too concentrated. So then they started switching to this pressure bag delivery with a really with your cardioplegia delivered straight crystalline into the heart. Didn't have super precise delivery pressures or amounts. And then finally, we moved over to the roller head. However, this preservation technique is still what is widely used for all transplants, including hearts and then many other organs. So overall, the use of just pure crystalloid causes really significant hemodilution. It had a lot of edema, really dysregulated oncrotic pressures, significant reactive oxygen species, increase in production, and it had no metabolic or oxygen delivery. So there was kind of a big push for blood cardioplegia. Not only did it reduce reperfusion damage and limit hemodilution, it had its own natural oxygen carrying capacity, buffering capacity, normalized pH, had proteins, metabolic substrates, etc., all of which is really advantageous. The only kind of thing is that it increases your complexity of delivery. So we had to figure out how to deliver that with it mixing in blood. So now you have what we know today is your kind of cardioplegia delivery on a roller pump, changing and adding cardioplegia itself indirectly at whatever ratio you'd like, 4:1, 1:4, 1:8, 1:2, really whatever your heart desires, whatever the cardioplegia calls for. And then you can deliver it directly into the heart at your desired pressures, flows, and know the exact amount that you're giving, which is a lot more ideal and precise. The other kind of thing is if you want to give blood cardioplegia or microplegia, you do need an MPS or its own kind of delivery method. I think that MPS is the only one that does microplegia currently, but this is what that would look like. And that's going to be delivering your injections of concentrated ions and chemicals directly into the blood. So this is just kind of going from crystalloid to blood, which is still really widely used, and now the recent introduction of microplegia, which is also widely used, although this is still the main component or delivery method of cardioplegia. So one of the things to keep in mind, though, with blood cardioplegia is that you are dysregulating your dissociation curve for your oxyhemoglobin. So you have really cold blood that you're delivering. So you're shifting that to the left, which is going to increase oxygen's affinity for hemoglobin. However, you are delivering to an acidic environment, so that kind of shifts it back to the right, but it is something to be conscious of. Your ratio of blood to crystalloid does change depending on the ratio that you're delivering at, and that will have a direct effect on both your true concentration of ions, such as potassium, osmolarity, and hematocrit entering the heart, which you should be aware of. And then it does have to do with your blood viscosity. So the colder it is, the higher the blood viscosity, changing your flow dynamics. But then again, you are diluting with crystalloid, which is going to be changing that back. And then one of the things to be conscious of when you're delivering blood cardioplegia is that however your circuit is made up, it kind of increases your complexity rather than a pressure bag. So incorporating just our normal blood cardioplegia at those ratios, you can have your single pass or recirculating system. So single pass is what we use. Recirculating is just going to be a direct cardioplegia delivery system where it's recirculating only blood and cardioplegia. And then microplegia itself is a much more complex delivery system. It has very minute and precise additions, as well as a more complex circuit or mechanism itself with the MPS Quest, but it still all works well. Okay, so that's kind of more conceptual stuff. More on the clinical side, what options for cardioplegia do you actually have? So you have your intracellular cardioplegia, extracellular type cardioplegia. Both of these are going to be depolarizing potassium based. And then you have things that are more hyperpolarizing, non-polarizing microplegia options. So first, intracellular cardioplegia. These are going to be mimicking what would be intracellular conditions. So they have low electrolyte levels in general. They have high potassium and then low or absent levels of sodium and calcium. These are going to be things like histidine, So HTK, custodial HTK, generally used not so widely, although they are still used in some adult and then pediatric cases. They have a very long rest time, about 180 minutes, depending on cardiac preference or surgeon preference, etc. But it's delivered pure crystalloid or 1 to 4, and your dosage is 25 to 40 milliliters per kilogram. So that's like 2,000 to 4,000 milliliters per dose. Generally, because of the long time, you're not going to be redosing, but you can redose. And it's not widely used in cardiac surgery. It is more commonly used in abdominal organ preservation transplants or heart. People use hearts too. However, Celsius is going to be your most common heart or preservation technique. It was previously used in cardiac surgery, but like I said, now it's going to be mostly used for your heart preservation for transplants. It has an ischemic time of about 4 hours, and it is delivered pure crystalloid in about 2,000 to 3,000 milliliter doses. And then next up, you have extracellular solutions. So these are going to be more widely used clinically now. That includes your high K, low K, and del nido. These are going to follow the concepts of extracellular conditions, so high concentrations of potassium and the normal levels of magnesium, calcium, and sodium. And that high K, low K involves 2 different solutions with different potassium concentrations, which we'll go over in a minute. It has shorter acting arrest time, so 15 to 20 minutes when they need a new delivery. It's delivered 4 to 1. Your normal induction dose is about 1 liter, and your maintenance is about 500 generally. Del nido is a non-glucose-based extracellular solution, originally developed for pediatric, but now widely adopted for adult cases nationwide or worldwide. Its arrest is about 60 to 120 minutes. It's delivered generally 1 to 4. Your induction dose is about 1 liter to 1,200, and then your maintenance is about 500, again, every 60 to 120 minutes. And the one thing to be conscious about with that is that it does have very high levels of potassium and lidocaine, which we'll talk about later. And so sometimes with really long pump runs, you want to switch or not use as much in fear for overdosing those 2 things. Regardless, here we have kind of the equation for making formula for high K, low K, or St. Thomas. So your initial dose is going to start with this high K and deliver until EKG activity is eliminated. And upon elimination of EKG activity, you switch from high K to low K for the rest of the duration of your induction, as well as any redoses, unless EKG activity restarts, in which case you'll go back to high K until EKG is eliminated, and then you're going to go back to low K for the rest of that dose and maintenance. Okay, next up we have del nido. Here's your formula. As you can see, you have a higher concentration of lidocaine as well as magnesium. So the worry about it is that you're going to overdose it in really, really long pump runs, although not a lot of pump runs are super, super long, hopefully, depending on your surgeon. And then last up, we have kind of an example of hyperpolarizing or non-polarizing. So ALM, adenosine, lidocaine, and magnesium are the most common agents used for these. One of those is going to be something called adenocaine, as well as polar shot is going to be another version. But all in all, adenocaine is given through the MPS. It has a shorter rest time, so you have to be redosed every 20 minutes. Your initial induction starts in normothermia and then switch to hypothermia for a total of 6 minutes at different doses, and your MPS itself is what regulates and determines this and runs this. You just have to program it. And then maintenance is through adenocaine as well for 90 seconds each time. And then reanimation does require adenocaine administration and then just normal like hot shot post before your cross clamp is removed. So now we're going to talk about actual clinical delivery of cardioplegia and the options, just antegrade, osteal, retrograde, and graft. Let's talk about what would be required for both. Antegrade is again going down your normal physiological flow of your coronaries. It's being delivered into this isolated portion of your aorta, has to be given at a high enough pressure to close your aortic valve and then provide positive flow out through the coronaries. The one kind of thing to be conscious of is that if you have really bad coronary artery disease, say like on this LAD, you might want to be thinking about getting collateral flow or maybe retrograde or a flow to get these kind of further down parts of the heart. But all in all, when you're delivering, you want to give 100 to 150 with coronary artery disease measured at the root, right? That's not your back pressure, your pump, that's at your root. And then 50 to 90 without coronary artery disease, again, measured at the root, in order to provide closing for your valve as well as flow down. The only really main contradiction for antegrade cardioplegia delivery is going to be really severe aortic regurg, or AI, in which case this valve can't close or won't close, and it'll cause that cardioplegia to go into left ventricle, one, causing distension, and then two, obviously just not accomplishing arrest because it's not going down the coronaries. And the main kind of fix for that would be osteal. Osteal, again, goes normal physiological flow down, but it does require for you to open up the aorta, have an osteal perfuser, a handheld perfuser, and then deliver down each coronary directly. Again, you're going to go for a similar pressure of about 100 to 120 down each, but you should be conscious of the fact that the right is about 10% smaller than the left. So it does take a little bit reduced flow to get similar pressures on each. And then next you have retrograde cardioplegia. Try to get this out of the way. So retrograde cardioplegia is going to involve placing your cannula, your retrograde cannula, blindly into the right atria, placing it in the coronary sinus, inflating the balloon either manually or through a self-inflating cannula, so that it provides backwards flow at positive, safe pressures through the great veins, back through the cardiac arteries, and then out into the aorta. So here you need to have some kind of venting system, whether that is your vent that is going to be on or it's just your aorta being open. And you want to deliver at about 40 to 50 millimeters of mercury measured at the coronary sinus in order to both ensure positive flow, but not over pressurize and rupture this coronary sinus. One thing you do need to be very conscious of is the fact that your retrograde cannula is placed through blind placement, right? So it's in the right atria and you can't actually see it. You can feel it, and surgeons are very well trained to place it, but sometimes you do need to verify this with TEE because, as you can see, that is a pretty blind placement. You know it's in there and you can feel it, but you aren't always 100% sure. So if you have any type of anatomical anomalies, it potentially can feel like it's in, but then not be delivering, or it's not actually in, it's just delivering directly to the right atria, or it is in, but it's in a wrong angle or wrong way. So then you're just going to be delivering directly into the wall, possibly rupturing it. So again, you want to test that by feel. Surgeon can feel it. TEE with anesthesia if you're unsure. And you can also verify that with your pressures, your visualization of EKG arrest, temperature drop, etc. when you're delivering yourself. Okay, and then last up is going to be your graft delivery. This is not an initial induction delivery method, but it does work very well for providing kind of added protection as well as testing the anastomoses of your grafts with CABG. So you have the distal side sewn on, and then using either the line itself or an osteal perfuser, the surgeon will hold and deliver cardioplegia distal to whatever that blockage is through the graft. The pressures you're trying to mimic are going to be kind of normal systolic pressures, so like 100 to 120, and this allows for testing and added protection past wherever maybe you didn't get super well protection if you only gave antegrade with coronary artery disease. So the other kind of component of clinical delivery is the temperature at which you're delivering cardioplegia. Most common delivery is going to be cold. Your target septal temp for that is going to be 10 to 15. So with your asystole of cardioplegia, as well as that cold hypothermic delivery, you get a 97% reduction in oxygen demand. And it should be worth noting that delivering at like 2 to 4 degrees Celsius of cardioplegia doesn't hurt the myocardium, so it isn't detrimental or harmful. And then with every 10 degrees Celsius decrease, you get a 50% enzyme activity reduction, which is really significant in protecting the myocardium. And then one kind of component with cold delivery is that ice slush is often also added to maintain that cold heart. However, ice slush has been shown to cause some phrenic nerve palsy and then kind of increase your post-op ventilation as well as increase respiratory complications post-op. It doesn't really stop people from doing it, but you should be conscious of it. And then the other kind of temperature delivery that is possible is warm delivery, whether that is a warm induction where you start delivering warm and then switch to cold. That was shown to kind of preserve ATP stores, although it's not super widely used anymore. And then the other kind of warm delivery method would be something called warm continuous delivery, as a much older technique that isn't super widely used anymore, but it's when you're giving retrograde cardioplegia throughout the entire operation warm, usually something like low K, in order to maintain arrest without having to expose the heart to any side effects from hypothermia. So, the last thing about the cardioplegia delivery is something called a warm shot or a hot shot, right? So that's given just prior to removal of the cross clamp to help kind of facilitate early recovery of metabolic function, as well as like reinstate your ATP and metabolic reserves. So there's kind of two ways to do hot shot. One is going to be blood only. It's the most commonly used one now. It supplies your metabolic substrates, kind of reinstating your ionic imbalance. And the thought is that you're also kind of like decreasing your cross clamp time. But either way, the other type of hot shot that can be given that was originally introduced was cardioplegic hot shots. So that's giving normothermia cardioplegia through the heart prior to removing the cross clamp. And the idea is that you want to deliver metabolic substrates and replenish ATP stores while still arresting the heart in diastole. So it's not using energy, it's just resupplying substrates and energy. So that way it has like the best chance of recovery once you remove the cross clamp and start reperfusion with blood only. However, it wasn't really shown to be significantly better than blood only, so that's why blood only is kind of mainly used now. However, it is still a technique that is used or was used. Overall, though, the hot shot itself really does improve metabolic and myocardial contraction upon reperfusion or cross clamp removal, and it does have a reduced trend of troponin levels for recovering patients, so that's pretty advantageous. But all in all, that is my cardioplegia lecture. So just to review, your general goals were myocardial protection with hypothermia and chemical arrest, and that can be delivered via different types of solutions and different routes, creating your still ideal protected bloodless field. And your makeup of cardioplegia is really trying to be optimized using different methods of chemical arrests, different agents, different additives, and different ratios, all of which have different advantages to protecting the heart. And there are some risks and adverse effects that are unavoidable or slightly avoidable with cardioplegia and reperfusion, that being like reperfusion injury, ischemic events, stone heart retrograde placements, etc. All of which overall the good does outweigh the bad. So that's why we obviously still use cardioplegia. Okay, thank you so much. Please take the quiz after. And here are all of my sources. Okay, thank you so much.